Good evening friends, this is Dr. Chaitanya and welcome to my channel Critical Care Basics. And in this channel, as you all know, we are running ECG tutorials and this is the 37th ECG tutorial. Today's tutorial is on ventricular ectopics or ventricular premature contractions. So let's start ventricular ectopics. Now ventricular ectopic is an ectopic impulse that arises prematurely. What happens normally is an impulse starts from the SA node and then goes to AV node and via bundle of His into the bundle branches and the Purkinje fibers. But all the cells of the heart have a property to depolarize spontaneously, what is called as automaticity. So they can spontaneously, even the ventricular cells can spontaneously depolarize at a rate of 35 to 40 per minute. But as we go up the conducting fibers like AV node and the SA node, thus their speed of automaticity is higher. Because the speed of SA node is the highest, SA node rules the heart. So the heart is in sinus rhythm. Whenever SA node fibers fires, all the lower impulses are suppressed. But sometimes the ventricle, there is an abnormal focus in the ventricle that starts firing and that impulse can depolarize the ventricle, and this is what is called as premature ventricular contraction or premature ventricular beat. Because this impulse travels through the muscle fibers and not through the proper conducting system, therefore this travels slowly and travels in a bizarre fashion. And therefore the QRS is wide. So in a ventricular ectopic, because the beat is not coming from the sinus node, there is absent P wave preceding the ventricular beat, and the ventricular depolarization QRS complex is wide and bizarre, right? And the abnormal depolarization is followed by abnormal repolarization. So the T wave and ST segment are directed opposite to the QRS complex. So that brings us to the characteristic features of ventricular ectopic. How to diagnose ventricular ectopic on an ECG? There will be no preceding P wave. Number 2, broad QRS complex, more than 120 milliseconds usually, that means more than 3 small squares, and it is premature, that it comes before the normal sinus beat where it is expected, it comes before that. And discordant ST and T wave changes, means the ST-T is usually directed opposite to the QRS vector and usually followed by a full compensatory pause. We will come to compensatory pause later. And retrograde capture of atria may occur. So there is no preceding P wave, but this ventricular ectopic beat or ventricular ectopic impulse can get retrogradely conducted to atria, causing a P wave or P prime wave or retrograde P wave. So as you can see, this is a premature wave, this is a sinus beat, again a sinus beat, and this is a premature impulse because it is coming before. Normally the QRS complex should have come here, but this beat comes before the expected time, and there is no preceding P wave. This is broad QRS complex, wide QRS, and discordant ST. The ST is directed opposite. And the compensatory pause. After the ventricular ectopic, the ventricle does not accept the sinus impulse that is coming, that should have come here because ventricle already is depolarized. So that time is missed and the next sinus beat comes on a regular time. So this RR interval, that is interval from the preceding R to the following R, is exactly double the normal RR interval. So that is called as full compensatory pause. We will come to it again later. So this is what is called as appropriate discordance. Whenever the main QRS complex is directed upwards, in those leads the ST segment will be depressed downwards but convex upwards and T will be inverted. Whenever in those leads where there is predominant S wave, or predominant Q wave, QRS complex is predominantly negative, there the ST segment will be elevated with concavity upwards and T will be directed positively upwards. Now these PVCs can come in repeating patterns, like bigeminy means every alternate beat is a ventricular premature contraction, trigeminy every third beat, quadrigeminy every fourth beat is a ventricular ectopic. Couplets means two ventricular beats coming one after the other, two in union, and whenever there are three or more beats coming together, then this is called as non-sustained ventricular tachycardia. If it exceeds more than 30 beats, then that is sustained ventricular tachycardia. Now these ventricular ectopics could be unifocal or multifocal. Unifocal ectopics will look all same. You see the pattern of ventricular ectopic, they are looking exactly the same. That means they are coming from the same focus. While here this ventricular ectopic and this one are different in shape, this one is different in shape. That means they are coming from different foci. Now you can actually have an idea as to where the ectopic is coming from, because the right sided ectopics which originate from the right ventricle will usually have a left bundle branch block pattern. For example, in the upper ECG, the ectopics are arising from the right ventricle, and you see the tall QRS complex in R and deep S, tall QRS complex in V6 and deep S in V1. This QRS is also wide, so this is like LBBB pattern. And the lower ECG shows an ectopic which is arising from the left ventricle. Here you can see typical RS R prime pattern in V1 and oppositely directed T wave and S waves in V6. So left sided ectopic will have a RBBB pattern and right sided ectopic will have a LBBB pattern. This is an example of ventricular bigeminy. Sinus beat, ectopic, ventricular ectopic, sinus beat, ventricular ectopic, sinus beat, ventricular ectopic. So every alternate beat is a ventricular ectopic. So this is an example of couplets. Two beats coming together, two ventricular ectopics coming together, and when they are more than three, then it is called as non-sustained ventricular tachycardia. So this is ventricular tachycardia. If this continues for 30 beats, then that is called a sustained ventricular tachycardia. Now again, regarding the compensatory pause, this is the difference between the atrial ectopic and a ventricular ectopic. This is an atrial ectopic. How will you tell that this is not a ventricular ectopic but an atrial ectopic? First of all, how will you say this is an ectopic? So this is the sinus rhythm PQRST, PQRST. Here you can see the P wave, but the shape of the P wave is different from the normal sinus P waves. What does this tell? That this is arising from the atria but not from the sinus node, and this is coming prematurely. Normal sinus beat was expected here, but it has come prematurely. So this is a premature atrial. Why atrial? Because you can see the P wave and the QRS is normal, so ventricular conduction is normal. So this is a premature atrial ectopic, and here the ectopic travels and it resets the sinus node. So the normal beat which was supposed to come here does not come here and comes, the next sinus beat which was supposed to come here does not come here and comes here. So the compensatory pause, the interval between the R of the previous beat from the ectopic, this is the atrial ectopic, the distance between R of previous beat and the next beat after the ectopic is less than double of the RR interval. So this is called as incomplete compensatory pause in atrial ectopic. While in ventricular ectopic, you see this is ventricular ectopic. Why this is ectopic? Because it is coming before. This is the sinus rhythm, PQRST, PQRST. The next beat would have been expected somewhere here, but it comes early. So this is premature. There is no preceding P wave, and this is a wide QRS and bizarre complex, T wave directed opposite to the QRS complex. So this is a ventricular ectopic, and this ventricular ectopic is not traveling to the atria. So normal because the ventricle is already depolarized, the sinus beat also does not come here. The next sinus beat comes on time. So therefore, the interval between the preceding R and R after the interval or after the ectopic is exactly double of the RR interval. So this is full compensatory pause. Again, you can see here, sometimes there could be incomplete or partial compensatory pause. In the upper example, you have full compensatory pause. This is the sinus beat, this is an ectopic, and you can see that this interval 1700 milliseconds is same as double of the RR interval here. This is because neither this beat goes retrogradely to atria nor the sinus beat comes down. So the sinus beat comes on time. So this is full compensatory pause. While here, after the ectopic, it is retrogradely going in the atria, and this does reset the SA node. Hence, the time interval between the preceding R and the following R is not double the normal sinus RR interval. So this is partial compensatory pause. So not all the ventricular ectopic will have full compensatory pause. If the ventricular ectopic has a retrograde P wave going upwards, then there could be partial compensatory pause. Sometimes atrial rhythm could be confused with a ectopic, ventricular ectopic. See this example. This is looking like a wide QRS complex, bizarre, but notice the P wave. This P wave is different than the sinus P wave here. So this is an atrial ectopic with RBB type ventricular aberration. So this is not a ventricular ectopic. Now, ventricular ectopics are reasonably common in general population, but usually they are in very low numbers. They are more likely to be detected in older patients and patients with comorbidities, and when you monitor them for a longer duration. For example, in patients with no structural heart disease, if you monitor ECG for only 30 to 60 seconds, only 1% will have an ectopic. But if you monitor them for more than 2 minutes, then 6% will have ectopics. And in 24-hour Holter monitoring, up to 80% people will have an ectopic. The occurrence of frequent PVCs, more than 20% of heartbeats, is seen in less than 2% patients. So this is called PVC burden. More than 20% mean 20% of all the heartbeats are ectopics. So this is reasonably rare, less than 2%. The prevalence increases with hypertension, hypokalemia, hypomagnesemia, and some other conditions. We'll talk about it. It is generally considered that the normal so-called number of PVCs in adult in 24 hours should be less than 500. So up to 500 ectopics, ventricular ectopics in 24 hours is considered normal. Vast majority of patients will not be symptomatic, so there will be no symptoms. PVC rarely cause true hemodynamic compromise, except when frequent ectopics in a poor LV function. If the LV function is poor and the ectopics are frequent, only then they will cause symptoms, or if there is underlying bradycardia. Syncope, the most dangerous symptom of a ventricular ectopic is a syncope, especially with no prodrome. Means there is no previous symptomatology before the syncope. Suddenly the patient drops down. Or if there is associated chest pain or dyspnea, this could signal an underlying cardiac disease, structural or electrical. The most common symptom, however, is palpitation. Palpitation results from hypercontractility of the heart after the ectopic. The next beat after the ectopic, heart pumps more. So that could be the reason for the feeling of palpitation, or the compensatory pause can give rise to feeling of a missed beat. You should also look for correctable causes or triggers. We'll come to the triggers later, like electrolyte abnormalities, underlying cardiovascular disease, or endocrine abnormalities. Usually physical examination is normal, inconsequential. Sometimes you could feel the irregular pulse, or rarely when there is AV dissociation due to an ectopic and atria contract on a closed ventricle, you could see A waves, Canon A waves. Or if the ectopy is coming from the RV, then you could see a delayed S2 sound, and a compensatory pause can sometimes be auscultated. There is something called as an R on T phenomenon, which sometimes can precipitate dangerous ventricular arrhythmias. So what is R on T phenomenon? Whenever an ectopic or any artificially created impulse lands on the T wave, that can cause precipitation of sudden ventricular arrhythmia, because as we all know, the QRS complex represents ventricular depolarization, while the T wave represents ventricular repolarization. So when the ventricles are repolarizing, if a powerful impulse action potential reaches the ventricle, it can suddenly depolarize and cause abnormal arrhythmia. So when the PVC occurs at or near the T wave apex, this is the vulnerable period, and it can cause sudden arrhythmia. It has little prognostic significance in most clinical situations. In most of the clinical situations, it is not significant, it is not dangerous. Even during the electrophysiology study, PVCs are usually applied on this vulnerable period of cardiac cycle without producing any malignant ventricular arrhythmia. But this R on T phenomenon could be dangerous in the patients who are at risk of polymorphic ventricular tachycardia or ventricular fibrillation, or those patients with acute myocardial infarction or some congenital syndromes like Brugada syndrome or malignant form of early repolarization, or some patient with idiopathic ventricular fibrillation. So this is an ECG. This is a normal beat, and this ectopic has landed on the T wave. And see what happens. Suddenly, because the ectopic or the impulse has landed on the T wave, it has given rise to ventricular fibrillation. You can see this ECG, this is the normal sinus beat, and this ectopic has landed on the T wave, which is the vulnerable period, and it has precipitated this ventricular fibrillation. So this is especially during the defibrillation attempt. Only indication for defibrillation that we give is for ventricular fibrillation, because there are no R waves and no T waves, only wavy pattern like this. But in all other rhythms, all tachycardias, whenever there is a rhythm apart from ventricular fibrillation, always give synchronized shock. What is synchrony function? It synchronizes your impulse with the R wave. So accidentally you don't land up causing this R on T phenomenon. So that type of shock, when you use synchrony, is called cardioversion and not defibrillation. So defibrillation is unsynchronized shock. It has to be given anytime. The only indication is ventricular fibrillation, but in all other arrhythmias you give synchronized shock. Why? To prevent this R on T phenomenon. Interpolated PVC is a PVC without a compensatory pause. So you see the normal sinus beat and this ectopic, immediately there is a sinus beat. So no compensatory pause. This occurs when the PVC occurs very early in the course. So this is interpolated PVC. Now the etiology of ventricular ectopics, they could be associated with hypertension, left ventricular hypertrophy, acute MI, heart failure, cardiac inflammations like myocarditis, arrhythmogenic right ventricular cardiomyopathy, hypertrophic cardiomyopathy, congenital heart disease, and idiopathic ventricular tachycardia. They could be also associated with some non-cardiac conditions like COPD, pulmonary conditions, sleep apnea syndromes, pulmonary hypertension, some endocrinopathies involving the thyroid, adrenal or gonadal abnormalities, and some drugs like nicotine, alcohol, caffeine, and decongestants, antihistaminics, and some illicit drugs like cocaine and amphetamine. PVC induced cardiomyopathy. This is a heart failure or a depressed heart function caused by the increased burden of the ventricular ectopics. And this is a reversible cardiomyopathy, even in the absence of ventricular arrhythmias or symptoms. So patient has only frequent PVCs, no ventricular arrhythmias or symptoms, but the patient has depressed LV function caused by the increased burden of VPCs. The risk factor are greater PVC burden and epicardial origin of PVC and the longer PVC QRS duration. So three important factors. One is the greater number of PVCs, second is epicardial origin and longer QRS duration of PVC. Some studies say that this cardiomyopathy takes many years to develop, but some animal studies have shown that you can see a deterioration in LV function in as soon as 2 to 4 weeks. Examination of PVCs, elimination of PVCs using ablation can cure this cardiomyopathy. So this cardiomyopathy is reversible, and as soon as the PVCs are eliminated by doing ablation, the heart function returns to normal. Now, management of the ventricular arrhythmia, ventricular PVCs. First, before going to management, we should get a risk assessment. Management of the patient with PVCs depends on whether the initial evaluation indicates that the patient is at high risk or low risk of ventricular arrhythmias. High risk features indicate more intensive treatment. If there are no high risk features, you can just treat conservatively or you can just observe. But if there are high risk features, then you may require to have some treatment. So how to delineate the risk? First, the symptoms. Some symptoms will tell you as to how much risk is there with the ventricular ectopics. If there are practically no symptoms or mild symptoms, patients do not require anything except reassurance. But if there is significant burden, the number of PVCs is very high and it is causing cardiomyopathy or reduced LV function, then they should be treated. And if the patient has syncope, especially without a prodrome, or it is associated with chest pain or dyspnea, these could represent PVCs associated with some underlying structural or electrical heart disease, and this is high risk. Now, what is PVC burden? PVC burden means the number of PVCs in one day. If the burden is very high, then they could cause PVC induced cardiomyopathy. High PVC burden is a predictor of PVC induced cardiomyopathy, heart failure and mortality. If the PVC burden is high, then these patients should be treated aggressively. Also, these patients will not be able to tolerate beta blockers because they are having cardiomyopathy, so you'll have to go in for ablation. So you can do monitoring with 24-hour or 48-hour Holter monitoring. PVC burden is supposed to be low if there are less than 1% PVCs or less than 1000 PVCs per day. If the PVCs are less than 15%, 1 to 15%, then burden less than 15% per day, then the burden is supposed to be intermediate. High burden is called when there are more than 15% of PVCs or more than 15,000 PVCs per day. So if this kind of burden is there, definitely you have to treat. These are the characteristics associated with high risk PVCs. First is increased QRS duration. The broader the QRS, the more dangerous they could be. Interpolated PVCs. Then PVCs involving the Purkinje system. These can trigger ventricular fibrillation and have a short coupling interval. What is coupling interval? The time interval between the previous R and the ectopic. Polymorphic PVCs means PVCs arising from multiple foci. PVC with highly variable coupling interval, beat to beat, every PVC is coming with a different coupling interval, or coupling interval is more than 60 seconds, then these could be dangerous. And coupling interval heterogeneity, we'll see in the next slide. So multiple PVCs with different coupling intervals, so this heterogeneity is associated with heart failure. And PVCs, right and left ventricular outflow tract PVCs also have been associated with high risk. So these are the high risk criteria for treatment. So as you can see in this ECG, this is depicting polymorphic ventricular ectopics. This is a ventricular ectopic, these ventricular ectopics, this is also ventricular ectopic. Every ectopic is coming from a different site. So multiple foci, so high chance of structural heart disease. This is coupling interval heterogeneity. Coupling interval is the interval between the previous R and the ectopic beat. See, the coupling interval here is 760, here it is 960, 560, 980, 1000, 670. So many ectopics with differing coupling intervals, that is called as coupling interval heterogeneity. Such coupling intervals have a high risk of causing heart failure. How do you evaluate these patients? The basic investigation is a 12-lead ECG, then 24-hour Holter monitoring. If the patient has a structural heart disease or there is a chance of PVC induced cardiomyopathy, or there is history of heart disease in the family or history of sudden cardiac death, then get an echo done and get an ambulatory Holter. You can also get a patch nowadays which can be used for monitoring. TMT is indicated when you have a suspicion of coronary artery disease. Normally what happens, PVCs are suppressed by stress or exercise, but sometimes PVCs occurring during exercise may be secondary to underlying ischemia or could represent adrenergic or catecholamine sensitive arrhythmias, right, like inherited channelopathies. Patient with exercise induced VPCs should undergo stress echo or cardiac MRI. Rare patients require cardiac MRI, like patient with high risk PVC features. We have seen high risk in symptomatology and high risk in the ECG criteria. Family history of sudden cardiac death, cardiomyopathy, or the patient has cardiomyopathy with multiple ectopics and the cause is not known. This can be particularly helpful in rare conditions like hypertrophic cardiomyopathy, cardiac sarcoid, amyloid cardiomyopathy and arrhythmogenic right ventricular cardiomyopathy. So CMRI is generally obtained when the patients are at high risk of cardiomyopathy or there is history of sudden cardiac death. Now, in addition to these tests, there are certain tests that you could advise as per the history. For example, you can get an idea about the trigger. For example, if the patient is alcoholic or takes alcohol, so trigger could be alcohol, so get a alcohol sensing done, urine toxicology done. If the patient is taking a lot of coffee, in the history, tell him to restrain. If the patient has history of taking recreational drugs, you could do screening for drug screen for cocaine, amphetamine. If the patient has vomiting, diarrhea, diuretics, is on diuretics, then probably patient has electrolyte imbalances, get sodium, potassium, magnesium done. If the patient has pulmonary disease like COPD or chronic lung disease, he could be hypoxic. So get an ABG done, see for O2 saturation. If the patient has symptoms or signs or history of hypo or hypothyroidism, get a TSH done. If the patient is taking digoxin, it could be digoxin induced, so get digoxin level done. If the patient has signs and symptoms of heart failure, then get a BNP done. If the patient is anemic, and get a CBC done. If the patient says that he has a lot of stress, so give him psychotherapy or do a counseling. And if she is a female in the perimenopausal age, then it could be menopausal, so treat accordingly. After getting the patient investigated, the first drug that you start is a beta blocker. So the first line therapy is a beta blocker. Exception is those patients with PVC induced cardiomyopathy or depressed LV function where beta blockers are contraindicated and you will have to go in for ablation. Commonly used beta blockers are cardiospecific like carvedilol or metoprolol. See for reduction of symptoms and titrate dose accordingly. Repeat ECG Holter monitoring after say about 3 months, and if the PVCs are reduced, continue the treatment. If more than 1 month of maximum beta blocker dose, if still the patient has no relief or if the PVC burden is high, then he could be a candidate for catheter ablation or you could add antiarrhythmic drugs. Beta blockers reduce the post extrasystolic potentiation via the Starling mechanism. What is Starling mechanism? Increase initial fiber length is directly proportional to the contractility. So increase inotropy related to the increased stroke volume associated with PVC and reducing PVC symptoms. it should be recognized that they have no direct effects on the ventricular myocardium. Therefore, the beta blockers most likely to suppress the PVCs that result from excess sympathetic stimulation or are catecholamine sensitive. Only those patients will have maximal benefit with beta blockers. So I have included two algorithms here for treatment of VPCs. So first you do evaluate, correct the triggers, look for structural heart disease, electrical heart disease, and then see whether the patient is symptomatic. If the patient is not symptomatic, which is more likely, then see for the PVC burden in the Holter. If it is more than 10 to 15% or more than like 10,000 PVCs per day, then if heart failure symptoms, ablation. If no heart failure symptoms, you can try beta blocker, or if beta blockers are not helpful, ablation. If the PVC burden is not high, does the patient have high risk for high risk markers for electrical or structural heart disease? Yes, then initiate beta blocker. If the answer is no, no structural heart disease, PVC burden not high, then only patient requires is reassurance. While if the patient is symptomatic, the drug you start is a beta blocker or a calcium channel blocker. Then see for the symptoms and whether the PVC burden is reduced. If the PVC burden is reduced and the symptoms are less, then continue treatment, ask for routine follow-up. But the symptoms are persisting and the PVC burden is high. High PVC burden, more than 10 to 15% or more than 10,000 PVCs per day. If this is yes, the answer is yes, then catheter ablation or antiarrhythmic drugs. If the answer is no, consider changing the drug, or if it does not help, you may have to do ablation again. Lastly, approach to PVC treatment in high risk patients. So you have to be more careful in treating VPCs if the patient is high risk. We have already seen what are the high risks, like increased coupling interval heterogeneity, wide QRS, the PVCs arising from the outflow tracts, and so on. So if the high risk is confirmed, patient has suppose a structural heart disease like HCM, CAD, inherited arrhythmia syndrome, assess and manage triggers. Now, is it isolated cardiomyopathy, no structural or electrical heart disease? If that is the case, then presume PVC induced cardiomyopathy. The patient has cardiomyopathy but no structural or electrical cardiac disease. Then you presume that this is PVC induced cardiomyopathy. Are heart failure symptoms present? If yes, initiate heart failure treatment, proceed for ablation. If there are no heart failure treatment, try monotherapy with beta blockers. If there is no improvement in 1 month with maximal dose, you may require ablation. If the patient has underlying cardiac heart disease, then initiate monotherapy with beta blockers, treat the underlying cardiac disease, and you may require antiarrhythmic drugs or ablation. So this is all about the ventricular premature contractions, the ECG findings, the symptoms, and evaluation and treatment. Thanks a lot. If you're liking these lectures, please like, subscribe, and share.